Okay, welcome to the deep dive. This is where we take source material, maybe articles, sometimes research, but today, some really focused revision notes, and we just pull out the absolute essentials for you.
Yeah, we cut through the noise. The goal is to get you the high-yield info, the stuff that really matters for understanding, especially if you're trying to revise or get up to speed quickly.
Exactly. We connect the dots, try to find those aha moments. And today we're diving into notes specifically on Pseudomonas aeruginosa. It's based on excerpts from Pseudomonas aeruginosa, clinical overview, and management revision notes.
Perfect for anyone maybe prepping for exams like the MSRA or just needing a solid grasp of this pretty significant bacterium.
Right. So our mission today, walk through these notes section by section. We'll pinpoint the must-know facts, flag potential tricky bits, and maybe to offer a few memory aids along the way.
It is a medical topic, definitely dealing with a tricky bug,
Yeah.
but we'll aim to make it accessible, pull out the key takeaways, and maybe even some surprising bits.
All right, then. Let's get into it. This opportunistic character, Pseudomonas aeruginosa.
Let's do it.
So, starting right at the top, definition and overview. What are we actually dealing with here?
Okay, so fundamentally, it's a gram-negative bacterium. Now, the gram-negative part is about staining, but the really crucial thing from these notes, it's an opportunistic pathogen.
Opportunistic, so it doesn't usually cause trouble unless it finds an opening, a weakness.
Exactly that. It's all around us, soil, water, plants, that kind of thing. Healthy people, usually not a problem. But if someone's immune system is down or there's a break in their defenses,
Then it jumps in.
precisely. And the notes really stress its role in hospital-acquired infections. It's notorious there. Plus, and this is a big one, it's known for being resistant to a lot of antibiotics.
Okay, so common in the environment, but mainly a threat to vulnerable people, especially in hospitals, and it's tough to treat. Got it. Where does it actually cause infections? The notes list quite a few places.
It's really versatile, yeah. The big ones highlighted are chest infections. It's a major, major problem for people with cystic fibrosis,
Right, CF always comes up.
always. Then there's skin and soft tissue infections, think burns, surgical wounds, and interestingly, it's the culprit behind hot tub folliculitis.
The hot tub breath.
That's the one. Also, ear infections, specifically a nasty one called malignant otitis externa, often seen in people with diabetes. And UTIs, urinary tract infections, very common in hospital settings.
Okay, so chest, especially CF, skin, burns, wounds, hot tubs, ear diabetics, UTIs, hospital. That feels like a core list. For revision, maybe creating a mnemonic or just visualizing those areas could be helpful.
Absolutely. Anchoring it to those key sites, chest, skin, ear, urinary, that's definitely high yield for recall.
So etiology, where it comes from, we touched on soil and water. How does the infection actually start?
Well, it lives in those places, yes. Soil, water, damp environments, even in hospitals sometimes. The notes point out that infection typically kicks off when our natural barriers are breached. A break in the skin, a cut, a burn, or maybe damage to mucous membranes, perhaps from, say, being on a ventilator or having a catheter inserted. It needs a way in past our first line of defense.
Which leads perfectly into risk factors. Who are the people most likely to have these breaches or weakened defenses that this bug exploits?
Yeah, the notes list several key groups and situations. First off, prolonged hospital stays, especially in intensive care. The longer you're in that environment.
The higher the risk. Makes sense.
Definitely. Then, invasive medical procedures. Things like urinary catheters, breathing tubes, any kind of surgery, really. They basically create entry points.
Right, bypassing the barrier.
Exactly. And of course, anyone with a weakened immune system being immunocompromised due to illness or maybe medications, that's a huge factor.
Okay.
Then there are specific conditions that make people much more vulnerable. Severe burns, obviously. Cystic fibrosis, we mentioned that the lung environment itself is favorable. And diabetes, particularly for those ear infections.
Diabetes again? Okay.
And the last one is kind of direct exposure, contact with contaminated water, maybe poorly sterilized medical equipment.
That list is quite comprehensive but logical. Maybe for remembering, you could group them, like hospital stuff, stays, procedures, immune status, specific conditions, burns, CF, diabetes, and then exposure.
Yeah, chunking the information like that is a great revision technique. Makes it less overwhelming than just a long list.
So once it gets in, how does it actually cause disease? The pathophysiology bit. What are its weapons?
Right, its virulence factors. It's got a few nasty tricks. The notes highlight two main toxins, endotoxin and exotoxin A. Endotoxin is part of the bacterium itself and triggers a really strong inflammatory response, which can lead to serious problems like septic shock.
Okay, bad news. What about exotoxin A?
That one's maybe more targeted. It gets inside our cells and messes with their ability to make proteins. Basically, you can shut them down.
Nasty tools indeed. And the notes also mention biofilms. Why is that such a big deal?
Biofilms. Yeah, they're crucial. Think of them like the bacteria building a protective shield or fortress around themselves. They form these slimy communities.
A fortress made of slime.
Sort of. And this shield makes them incredibly resistant. The immune system struggles to get at them, and really importantly, antibiotics find it much harder to penetrate and work effectively. It's a key reason Pseudomonas infections can be so stubborn.
Wow. Okay, so it breaks in, uses toxins, hides in a biofilm fortress. Quite the opponent. Let's talk epidemiology. How common is it, especially in the UK, based on these notes?
The notes confirm it's mainly seen in healthcare settings in the UK. Very common in hospitals, particularly, as we said, in ICUs, critical care. The exact numbers vary, but the pattern is clear. It's a hospital-associated issue, primarily.
And if someone does get it outside of hospital?
It's usually linked back to those environmental sources, like contaminated water. Healthy people rarely get serious infections from the community. But what's really striking in the notes is a statistic about bacteremia, that's infection in the bloodstream. Between 2013 and 2017 in the UK, there was a 26.6% increase in Pseudomonas species bacteremias.
Wow, over a quarter increase in just 4 years. That's significant.
It really is. It highlights why it's such a focus. The notes also draw an important line between just having the bug present and actually being infected.
Colonization versus infection.
Exactly. Apparently, about a third of hospital patients might be colonized. The bacteria is there, maybe on their skin and their airways, but it's not causing disease. Whether it becomes an infection really depends on the patient's health, their immune status. Back to that opportunistic idea.
And we have to mention cystic fibrosis again here. Its impact is huge.
Absolutely crucial. The notes state it's the most frequent cause of chronic respiratory infection in people with CF. They even mention an estimated 80% colonization rate. That just shows how tied this bug is to CF care.
80%. Okay. So let's move to clinical features. What do these infections actually look like? Given it hits so many places, the presentation must vary a lot.
It really does. Super diverse. Maybe we can go through the list from the notes and pick out a key feature or association for each to help it stick for revision.
Good plan. Let's start with respiratory.
Pneumonia is the classic one, especially the notes say in patients who are immunosuppressed or have existing chronic lung conditions.
Makes sense. What about bacteremia in the blood? What are the signs and how bad is it?
As we mentioned, high risk, particularly hospital-acquired. The notes give a stark figure. A case fatality rate around 27% in England back in 2017-18 for P. aeruginosa bacteremia. That's serious. Clinically, you look for signs of sepsis, fever, chills, maybe confusion, low blood pressure. It can progress fast.
27%. Wow. Okay. Skin and soft tissue. There's often a really specific sign mentioned, isn't there?
Yes, ectoma gangrenosum. The notes flag this. It's a pretty distinctive. Skin lesion starts maybe as a reddish spot, then turns into a dark, blackish ulcer, often with a red halo. Seeing that really points towards severe Pseudomonas infection, often with bacteremia.
Ectoma gangrenosum. Got it. Any other skin things?
Yeah, the notes also mention the hot tub or swimming pool folliculitis again, and even green nail syndrome.
Green nails. Seriously?
Yeah, the bacteria produces pigments that can literally stain the nail green. Definitely memorable.
For sure. What about the heart?
Endocarditis infection of the heart valves. And the notes make a key link here. It's often seen in intravenous drug users. So that's a specific risk group for this type of Pseudomonas infection.
Okay. Central nervous system. Brain and spinal cord.
Less common, but serious when it happens. They can cause meningitis or brain abscesses.
And ears. You mentioned that malignant otitis externa.
Yes, that's the big one for ears. A severe infection of the ear canal that can actually invade the surrounding bone and tissues. The notes really hammer the link with diabetes here. Also, it's a common cause of chronic middle ear infections, otitis media.
Right. The diabetic link for malignant otitis is key. Eyes.
It can cause nasty eye infections. Bacterial keratitis, which is infection of the cornea, scleral abscesses, and endophthalmitis, an infection inside the eyeball itself. These are often emergencies. Potential site threatening.
Okay. Bones and joints.
The notes list typical sites, the spine, the pelvis, and the sternoclavicular joints, where your collarbone meets your breastbone.
Got it. Gastrointestinal tract? Gut infections?
These can vary. sometimes just diarrhea. But it can cause more severe inflammation like enteritis or something called typhlitis, which is a really severe inflammation of part of the colon, often seen in immunocompromised patients.
And finally, urinary tract.
Yeah, as we said before, often hospital-acquired, frequently linked to having a urinary catheter in place or recent urological surgery. Again, it's about that breach in the normal defenses.
Phew. Okay, that's head to toe, almost literally. For revision, definitely using that system approach. Respiratory blood, skin, heart, CNS, ear, eye, bone joint, GI, urinary, and attaching a key feature or risk factor seems the way to go, like ear malignant otitis plus diabetes or skin eczema plus hot tubs plus burns.
Absolutely. The systematic review linking site to feature is a very solid strategy for learning this.
So, with all these possible symptoms, how do doctors figure out it is Pseudomonas and not something else? Differential diagnosis.
Yeah, it's crucial because other things can look similar. Other bacteria, even fungi or viruses, especially in vulnerable patients. So you have to consider them. But the notes are really clear. You can't just guess. Laboratory tests are essential for actually nailing the diagnosis. You need to find the bug.
Which takes us neatly to investigations. How did the labs actually track it down?
The absolute cornerstone, according to the notes, is microbiological culture. You take a sample from where you suspect the infection is sputum for a chest infection, urine for UTI, a swab from a wound, blood.
And grow it in the lab.
Exactly. Grow it, identify it as P. aeruginosa. But then comes the absolutely vital next step, susceptibility testing.
Right. Finding out which antibiotics will actually work against that specific strain of the bacteria.
Precisely. Given how common resistance is with Pseudomonas, this isn't optional. It dictates treatment. If systemic infection or sepsis is suspected, blood cultures are a must. Imaging, like X-rays or CT scans, can help see the extent of the infection, like a pneumonia. And obviously you need site-specific tests, sputum culture, urine culture, stool culture, depending on the symptoms. The notes also mention checking the patient's overall status, things like a full blood count, maybe markers of diabetes control, tying back to those risk factors.
Okay, so culture first, then sensitivity testing is king. What about management? Once you know it's Pseudomonas and what kills it.
The golden rule, hammered home in the notes,
Mm-hmm.
use antibiotics based on those susceptibility results. You might start with an educated guess, what we call empiric therapy, based on the likely source and patient risk.
But you have to adjust once the lab results come back.
You absolutely must adjust. And for really severe infections, or if you're dealing with a known multi-drug resistant strain, the notes say combination therapy using multiple antibiotics is often needed. Consulting infectious disease specialists is usually recommended in those tough cases.
Makes sense. And preventing spread, especially in hospitals, must be huge.
Oh, massively.
Yeah.
Infection control basics are critical. Hand hygiene, hand hygiene, hand hygiene. Plus, properly sterilizing equipment, especially invasive devices. It's fundamental.
The notes list quite a few antibiotic classes that can work. Any key ones to flag for revision?
Yeah, there's a list. It includes certain third-generation cephalosporins, then the carbapenems, things like imipenem, meropenem, they're quite powerful. Aminoglycosides like gentamicin or tobramycin. Colistin is often reserved for very resistant bugs. Piperacillin tazobactam is common. And ciprofloxacin, a fluoroquinolone.
That's quite a few names. Maybe focusing on the classes, cephalosporins, carbapenems, aminoglycosides is more manageable?
I think so. Knowing the major classes that have activity is probably more useful than memorizing every single drug name initially. The notes also point out that treatment isn't just about drugs.
Right, surgery sometimes.
Yes, sometimes surgery is needed. This might be debridement, cleaning out dead or infected tissue, or removing an infected device like a catheter, or maybe an artificial joint. And for specific problems like malignant otitis externa or severe bowel issues, or that eye infection endophthalmitis, surgery can be crucial. They mentioned vitrectomy surgery inside the eye for endophthalmitis specifically.
Okay, so it can be a real combined arms approach.
Yeah.
What about the long-term prognosis? What do the notes say about outcomes?
They're pretty clear that it varies hugely. It really depends on things like where the infection is, how severe it got, the patient's underlying health, and crucially, whether the bug is resistant to antibiotics.
So it could be anything from a relatively minor issue to life-threatening.
Exactly. But the positive note they add is that getting the diagnosis right early and starting the correct treatment promptly, based on those susceptibility tests, really does improve the chances of a good outcome. Prevention also plays a part in the long-term picture, of course.
What about things going wrong even with treatment? Complications?
Well, the big general ones listed are things like septic shock, organ failure, the infection becoming chronic and hard to shift, or dissemination spreading to other parts of the body. And there's a complication of the treatment itself. Using antibiotics for a long time can unfortunately breed more resistance or lead to other infections like fungal infections or C. diff.
Right, the double-edged sword sometimes. Are there complications specific to where the infection is?
Yes, the notes list a few, like endocarditis can lead to blood clots breaking off and traveling thromboembolism. Malignant otitis externa can spread and affect nearby sinuses, the mastoid bone, even cranial nerves. Severe gut infections can cause serious bowel problems, and bad skin infections could potentially lead to gangrene.
Okay, definitely highlights the potential severity. Finally, prevention. We've touched on infection control, but what else do the notes emphasize?
It really comes back to those core practices. Strict hygiene, especially hand washing. Using careful, sterile techniques for any invasive procedures. Isolating patients with severe infections, like extensive burns, is also mentioned as important.
And equipment cleaning.
Absolutely vital, meticulous cleaning and disinfection. Another key strategy highlighted is actually avoiding the routine use of prophylactic antibiotics, giving antibiotics just in case. This can drive resistance, making future infections harder to treat.
Right, don't use them unless you really need them. Anything about future prevention strategies?
The notes briefly mention that vaccines are in development, which is hopeful. And they talk about using genomic sequencing, analyzing the bacteria's DNA to help track outbreaks, maybe pinpointing a contaminated water source in a hospital, for instance.
Okay, wow. We've covered a lot of ground there, from the basic definition, how it attacks, who gets it, what it looks like, finding it, fighting it, the outcomes. If you had to boil it all down from these notes, what are the absolute must-remember takeaways about Pseudomonas?
Looking back, I think the absolute core concepts from these notes are: it's opportunistic, thriving where defenses are weak, especially common in healthcare. It's versatile, hitting many body sites. Its resistance, often linked to biofilms, is a massive challenge. Therefore, prevention via infection control is key, and treatment must be guided by culture and sensitivity testing, sometimes needing combined therapy or surgery. Nailing those points gives you a really strong handle on it.
So for you listening, whether you're deep in MSRA revision or just expanding your knowledge, hopefully this deep dive has given you that high-yield overview, pulling out the critical bits from the source material.
Yeah, you got the essence of its opportunistic nature, the risk factors, the key sites, its defensive tricks like biofilms, and the absolute necessity of lab-guided treatment.
Okay, here's a final thought, building on all that. We know Pseudomonas loves water and healthcare setting. So, thinking bigger picture, how might things like, say, aging city water pipes, or the way we build and maintain hospitals, or even climate change affecting water systems, how might those wider factors shape the ongoing battle against Pseudomonas aeruginosa infections down the line?
That's a really interesting question to ponder. Lots of interconnected factors there.
That's something to think about. Now, if you are preparing for the MSRA, remember you can find more focused resources like this over at MSRA.com.
And for completely free access to a range of study materials, definitely check out freemjury.com.
Thank you so much for joining us on this deep dive.